Let me just say by way of introduction that X is probably the easiest section in the whole MDS. The reason is, most of the time, you're only going to do one item, and you're always going to enter a 1, and that's it. And number two, most of the time, if you're actually a person who needs to complete the MDS, the software that you're using should take care of almost everything in Section X for you. So there's really not a whole lot of thinking that's required for it. So mercifully, we have one easy section. I'm going to go through and explain how it works, just so you have, if you are a user of the software or you need to explain it to somebody else, you have an understanding of how it works. But it's pretty straightforward. Okay. All right. There are three things that you can do with Section X. You can either add a new record, which means you're submitting a new assessment for this person that's never been submitted before. You can modify an existing record, which means you've modified one, but you made a mistake and you need to fix it. Or you can request an inactivation, which means for whatever reason that you submitted an assessment for someone, but it never should have been entered and submitted, and you want to get rid of it. There is that one exception I talked about where, actually there's a few exceptions I'll talk about at the very end, where an inactivation isn't enough and you actually have to request that the record be deleted from the database. But that's fairly rare, and I'll talk about that at the end. Okay. I think this is just saying the same thing I just mentioned. Okay. The first item on X100 is the type of record. This item has to be completed on all assessment types and all record types, period, even the tracking forms of the entry and the death and facility tracking forms. And it's X100 and it has three options, which are add a record, modify an existing record, or inactivate an existing record. 99% of the time, you're just going to enter a 1 in X100, and you won't touch any other item in X. You won't have to do anything with it, because that's mostly what you're doing. You're adding new records. Once in a while, you're going to have to do a modification or an inactivation when you'll have to enter a 2 or a 3, and then you'll need to complete some other items in Section X. The request to add a new record means you want to add a new record that's never been seen before. Items in all the sections will be edited in a normal sort of a way, and the record will be rejected if there are any fatal errors. And the record will be rejected as a duplicate and have a fatal error if the record already exists with the same resident, facility, reason for assessment and tracking, and date. And the date would be what we call the target date, which would be the assessment reference date for an assessment, the discharge date for a discharge, or an entry date for an entry. So if you duplicate, you don't have to worry about that, because if you do duplicate, it's going to be kicked out by the system. The request to modify an existing record, there are a number of reasons why you might want to do this. If there's a transcription error, a data entry error, a software product error, item coding errors, or some other sort of error, and I'll go over those a bit. Oh, right here, actually. The transcription error includes any error made recording MDS assessment or tracking information from other sources. So if you're transposing the digits for the resident's weight and you put 191 instead of 119, that would be considered a transcription error. Data entry error means you had the right, if you're in a facility that's using paper forms, you had it right on the paper, but when whoever did the data entry, they made a mistake and just a clerical error. Software product error would include any errors that are created by your the software that your facility is using. And then an item coding error would mean any error made coding an MDS item, for example, choosing an incorrect code for an ADL, let's say. When you need to modify a record, you complete Section X to indicate that you're doing a modification, and you also complete all the items that need to be completed correctly. Correctly complete all the items on the other sections of the MDS. So you don't just submit Section X plus the item you want to fix. you've got to re-enter the entire assessment in the corrected fashion. Okay. And in Section X, you complete a set of items we call locator items, which help the system identify what the record is that you're correcting. Okay. An inactivation is for an inactivation request, you only submit Section X, and you complete those locator items so that the system can determine which item is being, which assessment needs to be located and inactivated, and then you indicate the reasons that you're inactivating it. Correction requests should be completed and signed within 14 days of detecting an error. Any change request must be kept with the modified or inactivated MDS record in the facility records. The change request can be retained in either the medical record or an electronic medical record, and the request must include a signature or electronic signature of the attesting facility staff. Okay, so that's sort of the overview. Now I'll go through what you do for the three types of situations, adding, modifying, and inactivating. So how do you add a record? In X100, you enter a 1, indicating you want to add a new record. You skip the whole rest of Section X and go on to item Z100 in the first item in Section Z, which is what Bob will be talking about. So that's simple enough. Modifying an assessment. You complete the following items. X100 to indicate it's a modification. X150 to 700, which is locator information are referred to help it find the previous erroneous assessment. A correction number. Reason for modification in X900. And then in X1100, the assessment coordinator's attestation of completion. So let's go through each of those items. X100, you code the 2, like I said, and you continue on to X150 through 700. And I'm not going to go over these. I'm going to kind of skip through these, but you can see each of these items parallels exactly one of the regular items in Section A. And what you enter in here, even if one of these items was incorrect on the previous assessment, the record you want to correct, you indicate exactly what was on the previous assessment. So you indicate the type of provider, which is nursing home or swing bed, enter the resident's name, just like you entered it before, their gender, birth date, social security number, and the reasons for assessment that you indicated on your previous assessment, and the dates, the ARD and so forth. And okay, this is just talking about how to fill out those dates. So just as an example, just to make it real clear, if you entered, let's say, the wrong birth date for the person, on here in the Section X, you would indicate the birth date that was incorrect, so the previous record could be found, but then in Section A, you would indicate the new corrected birth date. All right. Okay. So once you've entered the locator information, which your software should probably pull up for you from the previous assessment, then you'd go to X800, which is the correction number. And sort of by definition, the very first time you submit an assessment, it's the correction number 00. So if you're going to correct it, your first correction is in 01. If you had to recorrect it, it would be a 02, and you can go up to, you can correct it up to 99 times if you'd like to. After that, I think you maybe need to call somebody. X900, you indicate the reason for modification, which are the ones I'd referred to before, either a transcription error, data entry error, software product, item coding, or other. And then X1100 is the attestation section, and you indicate the testing individual's first, last name, the title, signature, although those aren't submitted, and then the attestation date. And then also you go on to complete the rest, the normal sections of the MDS for that assessment. And then the last transaction you can do is inactivation. This request to move the existing record to a history file, which sounds a little obscure, but basically what that means is that CMS still has an audit trail that that record was submitted, and they still have the information, but it won't be used for any reporting purposes. So, for example, if you submit a record erroneously and inactivate it, it doesn't get included in any of the QM reporting or any of the other reporting that you see. And to do an inactivation, you enter a 3 in code in X100. You enter the correction number, just like I was talking about before. And then you do the reasons for inactivation in X1050. And this is the last slide I wanted to mention when you have to do a manual deletion. As I mentioned, if a record really should not be in the database, then it can't just be inactivated. It needs to be deleted, and you need to submit a manual request for that. And there are 3 situations when you would need to do this. The first would be if you submitted a test record as a production record. So when you're testing your software, it may give you the option to do to submit some test records, with Mickey Mouse or whatever, and we don't like to see him in our database. So that would be a good opportunity if you did that by mistake to ask that record be deleted. If a record was incorrectly submitted was submitted with the incorrect option for A410. So, and remember, that's a submission requirement item. So like I was saying before, if you indicated that it, say, was federally required and it was not, then you need to have that deleted. And then also, if you somehow submitted the assessment under the wrong FAC ID, the FAC ID is the ID that the system uses to track facilities. If you submitted it for the wrong facility, then you need to have it deleted as well. And you do that by submitting a manual correction request to the state MDS coordinator, and they will have the record deleted for you. So that's Section X. I guess we're pretty much on time, and I'll turn it over to Bob.
Okay, now we're going to do Section E, the last section in the MDS. And basically, the intent of Section Z is to capture a number of billing items for Medicare billing, Medicaid billing, and also private insurance, other payors, and also to capture signatures and dates from the people who completed the assessment. And this also involves a attestation that's invoked with the signature that the people signing or certifying the accuracy of the MDS, a very important concept for ensuring accuracy. Okay, the first set of billing items have to do with Medicare Part A billing. And actually, the billing items are the items that we number people really like. Complicated algorithms, version numbers, the stuff that the world is really made of. And I know that the billing payment items aren't really of interest to most of you, but we're going to go through them anyway. Okay, so with regard to Medicare billing, there's a billing code called a HIPS code, Health Insurance Prospective Payment System Code, and it has 2 parts. The first part is a RUG code, and I'm sure you all know what RUG means. It's a 3-character group, part of a classification system that categorizes residents with regard to their nursing time and therapy time needs, and is the basis for setting the rates. This 3-position code is followed by an assessment indicator code, a 2-digit code. This is all the same as you would see on the MDS-2 in Section T under Item 3, T3. There was a Medicare HIPS code there. And this applies to billing for Part A Medicare covered stays. New with the MDS-3 is we actually have 2 Medicare billing codes. The normal Medicare billing code like you have on the MDS-2, but also a second Medicare billing code called a non-therapy code, billing code for Part A. And the non-therapy code is what you use when therapy ends. The day after all therapy ends, you discontinue billing at the rehabilitation rate and you begin using a rate for a group below that. This is one of the things at the end of therapy OMRA sets into effect. It gives you a code that you can bill. When you bill off of that assessment, you use the non-therapy code. There's also additional billing information in addition to Medicare. There's Medicaid. We'll talk about that in a moment. There's actually 2 Medicaid billing codes and also other payer, for instance, private insurance codes. Now into the actual items. ZO100A is the Medicare Part A HIPS code, and this is the normal code. It uses all of the more than 100 items on the MDS that are used in the RUG-4 system, and it includes the therapy items. There are 2 extra spaces at the end. There's actually 7 spaces long, and those 2 extra spaces are for future use. Not that we would ever change this, but just in case. And for all of the Medicare and Medicaid billing codes and the other items associated with Medicare and Medicaid billing, your software should calculate this automatically for you. Almost all software does. So you typically don't have to worry about figuring it out. There's some changes for the Medicare Part A HIPS. It's a new system. It's RUGS-4. The technical specifications, it's a 66-group model. It uses rehab classification appropriate to Medicare. There's another type of rehab classification that's usually used for Medicaid. And it's also index maximized, whatever that means. But there's a system that's used so that if a resident qualifies for several different RUGS groups, we want to put them in the group that's going to pay the highest, even if it's farther down in the RUG hierarchy. So for instance, if somebody is in low rehab and in special care, they'll almost always get classified into special care because the rate is higher. Changes concerning RUG-4, you're familiar with RUG-3. Rehab has changed. With Medicare and RUG-4, you record the number of individual minutes, the number of concurrent minutes, and the number of group minutes for a resident, and then these concurrent minutes get cut in half when making the classification. You report the actual numbers on the MDS, but the concurrent minutes get cut in half. There's also a limitation on group minutes. It can't be more than 25% of the total. You actually record the actual group minutes. The software, the grouper, the RUG-4 grouper will automatically apply that limitation for you. The logic for all of the lower groups has changed also. There are different qualifiers for extensive care. There are different qualifiers for clinically complex. The special care groups have been split in half. There's now high special and low special. You can say, well, I've got the same group I had with RUG-3. It's a BB1. It's not the same group. It's different. With RUG-3, that was behavior problems. Only with RUG-4, that could be behavior problems or cognitive performance problems. It's a different model. Even though some of the codes are the same, they don't have the same meaning. People won't fall in the same group. The assessment indicator code, the 2 digits at the end of the HIPS code, has changed completely too. It was fairly simple in MDS-3. You took the AA8A value, the OBRA reason for assessment, and concatenated it with the AA8B PPS reasons for assessment, and that was your code. Unfortunately, there were some cases where it didn't work, and so a better system has been worked out for RUG-4 and the HIPS code for Medicare now. It's relatively complicated. It's described in 2 tables in Chapter 6 of the RAI Manual, if you want to figure out how it works. One thing, a very, very major change is that with the MDS-2, the Medicare HIPS item was only active on PPS assessments. You had to have a PPS reason for assessment coded, or it wasn't active. With MDS-3, it is active on all PPS assessments and all OBRA assessments except for discharge assessments. So now on the admission assessment, the system is going to expect you to have that on an annual, on a quarterly. Now, if you don't complete it, if it's left blank, if your software doesn't do it or your software didn't set it up right, it doesn't matter, because what will happen is if you leave it blank, the facility will receive a warning on their final validation report that says you did not report a HIPS code. Here is the correct HIPS code if you want to use it for Medicare billing. It's only a warning. And it's also very helpful, because there are cases where a resident comes in and you really don't think that they are potentially Part A covered, and you do the admission assessment, and then you find out several days later that yes, their situation was present that they should have been Part A covered. You now have that RUGS code either on your assessment or on the final validation report to bill that assessment for Medicare Part A. If you submit the wrong RUG code, the system simply gives you a warning and tells you the correct one. I argued that you should be dropped from certification if you ever got this wrong, but there were forces at CMS that I couldn't handle, so it's a warning. It's not a tragedy. The next item is Z0100B, the RUG version code. And this is also something that we didn't have this on MDS-2, but this is just the version of RUGs that created the classification in Z0100A. Once again, your software should fill this out. If you have a burning desire to know what this is going to be, it's going to be 1.0066. Remember that. As of October 1st, and it won't change unless RUG 4 is revised at some future date, and that will be after I retire. On October 2nd, by the way. Okay, then there's also a new item, and this is the Medicare Short Stay Assessment Indicator. And this is the new concept, the Medicare Short Stay Assessment. And it's a fairly complicated concept to figure out the qualification for it. But the intent is if somebody comes into the facility and they're Part A and they're getting a rehabilitation regimen, but there hasn't been sufficient time to really get the full regimen going, you're not going to capture in the normal MDS rehab therapy items, 0400, you're not going to capture the information about what their full regimen would be, because that's assuming that you're reporting over a 7-day period. So if somebody comes in and they're only there for 4 days and they've been receiving rehab and some other conditions are met, this is also in a section of Chapter 6, then the assessment can be deemed a Medicare short stay assessment. By the way, you have to code it as a start of therapy OMRA in order to make all of the triggering happen. But if that happens, then you get reimbursed on the basis of the average minutes per day that therapy was given. And that gives you the ability to even get an ultra-high rehab category if somebody's there only 1 or 2 days. It's now possible. Before, with the MDS-2, there was no way to do that. There was an ordered therapy concept that gave you a little bit of a compromise. You might get a rehab group. It'd be a lower rehab group. But this is really a benefit, and it means that on the short stay, somebody went back to the hospital or the rehabilitation was completed after a short period of time, you will get reimbursed according to the level of service provided. So I think that that's a real improvement. For both the RUG version code, CO100B, and ZO100C, the Medicare Short Stay Assessment Indicator. If you leave it blank, you'll get a warning, and it'll tell you what the value should be. If you get it wrong, you'll get a warning, and the final validation report will tell you what it should be. Okay. Now we go to ZO150, and these are the non-therapy Medicare Part A billing items. These are new items. The first one, ZO100A, is a HIPS code, just like ZO150A is a HIPS code, just like ZO100A. It works exactly the same way, except it'll always be a non-therapy group. Essentially, the way that the grouper works is it ignores all the therapies in the items 0400 and then returns the classification. So somebody who is in high rehab may come out as classified in clinically complex or special care high. This is active on all assessments again, all over assessments except the discharge assessment and on the PPS assessment. The value will always be below the rehab groups. The assessment indicator, the last two digits, this is a 3-character RUG code and 2-character assessment indicator, 2-digit assessment indicator. The value will be exactly the same as AO100A for those last two digits. If the ZO100A group was a non-therapy group, ZO150A will equal it. If ZO100A is a rehabilitation group, ZO150A will be a lower group below the rehab groups. Now, hopefully, your software will take care of all of this. And it will never have errors. Okay, ZO150B is the version code, the RUG version code for the non-therapy RUG, and as of now, until revisions are made in the future, if they are, this will be exactly the same as ZO100B, that magic 1.0066 starting October 1st. Okay, well, now we can dispense with Medicare and move on to Medicaid. And if the state opts to require activation of Medicaid billing items on the MDS in Section Z in items ZO200 and ZO250, then these items will be edited by the system. And if the state has not turned this on, then these items will be ignored, and there will be no edits. And one thing that I found very interesting is with MDS2, there are about 35 states that use RUG3 for case mix payment, but only about half of them require the submission, require the facility to do the computation and submit it. The other states do the calculation on their own in their own internal systems, and you don't really need to submit it. So even if a state is doing case mix reimbursement, they may not require these items. And if these are activated on the MDS in Section Z, then they have to be a normal flavor of RUGs. They have to be one of the standard flavors of RUGs supported by the ASAP system. And that includes, for RUG 4, not only the 66-group model that Medicare uses, but also a 57-group model that collapsed the rehab groups from 23 to 14, and then even a simpler model, a 47-group model that collapsed the rehab groups down to 5. because for many states, they're not paying for rehab out of the Medicaid program in this way. They either have an alternative payment system. They're basically paying for nursing services. And so most states choose a simple system. Many states, I suspect, will choose the 48-group model. It's similar to what it is with RUG 3, and RUG 3 is still going to be active and can still be performed, and it should give results very, very similar to what you would get off of MDS 2. And there are 3 different models there. There's a 34-group model, the 44-group model, and the 53-group model. And they're the same. They reduce the number of rehab groups. There is no assessment indicator involved. Here we would expect to just see a 3-character RUG code. The version code, ZO200B, will be the version code for the RUG model that is used for the billing code in ZO100A. And those version codes, there's different version codes for all the different models. Those version codes, if you want to find them, are in the grouper documentation for the RUG 4 system and also the grouper documentation for the RUG 3 system. And if for some reason you want to know how these 2 models work, for the RUG 4 system, for the 66-group model, there's a worksheet in Chapter 6, and you can use that worksheet. And for instance, if you're using it with Medicare, that plus the CMIs that are used for Medicare can be used, and you can figure out how this thing works if you so desire. Also in the grouper package, if you want, there's SAS and C++ code that you can read. I'm sure that would excite all of you. And for RUG 3, there are worksheets for the 34, 44, and 53 group models that are available on the CMS website. Oh, and I forgot to mention, with regard to the Medicare short stay assessment indicator, there's a handout in your packet that has all of the requirements for having that happen. And there's also a insert in your packet that gives the Medicare urban and rural CMIs that go into effect October 1st. Insurance billing. There is an item present for insurance billing. This is there for the convenience of the facility. It is not accepted. If you happen to submit it, it is not accepted into the CMS database, and it is recommended that you not submit it. This is for your use, and you can communicate it to the other payor if that's necessary, but this is not information that is appropriate to send to CMS. It's there for your own, it's there for a facility's convenience. Okay. We get to the signature items in ZO400 and ZO500. And essentially, there's places that can be used to enter a signature for every single person who completed any part of the MDS. And their title and the specific sections or items they completed and the date that they were completed. And it's very important to ensure the accuracy of the MDS for a number of reasons. The MDS is used for a number of applications, including individualized care plan, the Part A Medicare prospective payment system, Medicaid reimbursement, quality monitoring like the QI/QM reports, facility quality improvement programs, data-driven survey and certification process, quality measures for public reporting, the nursing home compare and the 5-star reports, and research and policy development. It's very, very important that this information be accurate, and somebody has to sign and produce a date certifying the accuracy of all the individual sections and items. Now, a person may complete several sections, a person may complete part of a section, but that all needs to be documented on these signature lines. And if the person who completed the portion of the MDS did not sign it on the date that they completed it, that was on Friday, they come in on Monday, they're going to go to sign it. The date they put down is the date it was completed, not the date they signed it. Electronic signatures are okay given that state and local law permit and that it's part of the facility practice. So these can be electronic signatures in the electronic health record. If you make copies of the MDS, whether you're making a printed copy out of an electronic health record or you have an original in the medical record and you're copying it, all of these copies should be noted as a copy somewhere. It can be distinguished from the original. Okay, and then ZO500, this is where the RN assessment coordinator signs and dates the MDS as complete and verified. It's been checked, everything is there, it's correct as far as their knowledge goes, and they're not really responsible for the accuracy of all the sections completed by other people, but they're responsible for the overall completion and verification of the instrument. And if for some reason the MDS coordinator does not sign on the date that they finish the verification, this is different than the individuals actually completing it in ZO400. They should put in the date that they actually sign it. That's the final completion date for the MDS. Same electronic signature rules apply to that also. And that's the end of Section Z. We're now done with the MDS. Everybody go home.